Moving forward, I would request Dr. Kamal Arora, Dr. Nanda Kishore, and Dr. Karambir to please come forward and take the seats. Thank you.
Next topic is on cerebral autoregulation in neonates and inferences at current time. It's by Dr. Lakshmi Raman. She's a medical director for Ecmo from USA. I'm sorry, I don't know the hospital. But Lakshmi is authority for the neuromonitoring in neonates, and she's the best person to listen from. Thank you, Lakshmi. Welcome.
Thank you, and thanks to the organizing committee for inviting me for a topic that's very close to my heart. And I'm just going to slightly change the title, that it is not just neonatal but also pediatric patients. What is the work that we have done in the past? I will say almost now 10 years. I've been at this topic for the last 10 years trying to figure this one out. And I'll tell you, I don't think I've quite figured it out. And I'm going to tell you what we know and where the future goes. So in the next 15 minutes, I'm going to talk about neurological complications and neuromonitoring and what the study we have done in terms of cerebral autoregulation using near-infrared spectroscopy and diffuse correlation spectroscopy and where we are going from here. So this is it's not any new slide, all of you have probably seen. This is the latest ELSA registry report that shows the outcome of patients, and what I want to highlight is the outcome that you see for pediatric and neonatal patients. But then when you have neurological complications, these are the neurological complications that are reported in the ELSA registry, then you can see how the percentages fall significantly. So it's a very devastating complication, and so it's very important for us to figure out why this is happening and how we can potentially prevent it, and if it happens, how can we recognize it early and potentially treat it. So this is the latest ELSA registry report, again looking at the different complications, and you can see the survival again comes down significantly when you have these complications. So what are the reasons patients are at risk for neurological complications? And I think all of us would agree that these are some of our sickest patients who go on Ecmo. They are hypoxic, they are hypoperfused, they are acidemic. And then you put them on Ecmo, you subject them to not only inflammation from their underlying disease, but also inflammation from Ecmo circuit. You are giving them anticoagulation. They already have some disruption in their underlying coagulation. And then there is loss of pulsatile flow when you are on VA Ecmo, which causes changes in your cerebral blood flow. And when you're putting big cannulas in the neck, you're going to now interfere with the cerebral venous drainage as well. So what are the ways of monitoring these patients? All of us would agree that clinical exam is the best exam. But particularly in pediatrics and neonatal patients, we many times don't have that luxury because they are sedated, sometimes even chemically paralyzed, that our exam is limited. And so then we have to resort to other methods. So what do? We get serial ultrasounds. We typically get ultrasound before they go on Ecmo. But that is like I say that it is like looking at the brain with a black and white TV. So it's not going to give you much information. EEG, if clinically indicated, I don't think everybody has the luxury of continuous EEG like we have in our center, so we actually put everybody on a continuous EEG. And then, of course, if they have a major clinical exam change, then we take them down for CT. Then there are other methods that are more experimental and in research. So what is cerebral autoregulation? I think everybody who's an intensivist knows this curve where you say that the cerebral perfusion pressure, cerebral blood flow is maintained constantly at various ranges of mean arterial blood pressure. This is an intact cerebral autoregulation. So it's an important hemodynamic response to preserve the blood flow in the face of changing blood pressure. But we all know that when you have some brain injury, that this autoregulation curve is disrupted. And this can then lead to poor outcomes. So now I'm going to show some early animal data that was done. This is an early study done by Billy Short, where they looked at neonatal lambs. And this on the left is sham lamb where they did not get put on ECMO, and on the right are neonatal lambs which were placed on VA ECMO, and this is showing the cerebral blood flow in relationship to the cerebral perfusion pressure, and it is significantly altered compared to your normal animals. This was another study that looked at neonatal lambs, both on VV, which is represented in these light bars, and VA, ECMO, which is represented in dark bars. And they started looking at cerebral blood flow pre-cannulation to when they go on cannulation. And you can see on VA ECMO, there's a significant decrease in cerebral blood flow and increase in cerebral vascular resistance, particularly on VA ECMO. Then they looked at cerebral oxygen delivery using cardiac output and oxygen content, and you can see that the cerebral oxygen delivery is also decreased on VA ECMO. Now I'm going to switch a little bit of gears and talk to you about non-invasive ways of monitoring where we have done some research. So what is cerebral oximetry? It utilizes the principle that near-infrared light is absorbed differently between oxygenated and deoxygenated hemoglobin. So by now there are several studies both in pediatrics and in adults. This was a nice adult study where they looked at the cerebral oximetry, and it is the one thing to remember with cerebral oximetry is it's not an absolute number, but it is more a trend. And so here they looked at the trend of cerebral oximetry, and if your cerebral oximetry fell below a certain range, then and stayed below, then they did some interventions, like they increased the ECMO flow, they gave some packed red blood cells, and then they saw if the near-infrared cerebral oximetry levels came back up. If they did not, then they hiked them down for CT and found that they had a focal infarct or diffuse anoxic injury. There have now been more studies, and I don't have time to show them all. And this is a nice pediatric study where they looked between survivors and non-survivors and showed that the mean cerebral oximetry level was lower in non-survivors. And even among survivors, the SO2 level was lower in patients with brain injury. So how have we utilized this near-infrared spectroscopy? We have utilized a principle called wavelet transform coherence. It's nothing fancy or new. It has been utilized for a long time in physics, but the application here is to use to assess stationary or non-stationary signals, and in clinical settings we have used it to assess in where there is a dynamic signal and looked at correlation between two dependent variables. So, and this correlation or coherence is done then over time. So in this case, we evaluated the dynamic relationship between spontaneous fluctuations in blood pressure and changes in cerebral oxygenation. And these applications, the early study was done in neonatal ECMO by actually Aparna's group in Great Ormond Street, and in neonatal HIE patients by our own group, and several studies have been published. So what is new? We asked the question, can we apply this dynamic relationship to evaluate disturbances in cerebral autoregulation over time? And we said, can we utilize this relationship to predict intracranial events? So how did we do that? I'm going to talk you, just basically walk you through this wavelet transform coherence. This is ECMO time in minutes on the x-axis, and this is the frequency of the wavelet on the y-axis. And we are looking at coherence between the two signals, which means the cerebral oximetry and the cerebral blood pressure, mean arterial blood pressure. And if those two signals are talking to each other, then you have a lot of coherence. So you see a lot of orange. So just in simple terms, you don't want to see a lot of orange, which means there is impaired autoregulation. So our study aim was to evaluate cerebral autoregulation measurements and correlate with neuroimaging scoring. And we did this by either CT or post. It is a standard of care in our institution for everybody to get post-ECMO MRI. And then we had two neuroradiologists who are blinded to the clinical exam and the clinical information, and they would score by a methodology that was published several years ago by Taylor et al. And then we have modified it now for MRI, and we have now had several publications where we have validated the scoring. And so we obtained clinical data we needed continuous cerebral oximetry and blood pressure measurements, and we used neuroimaging. So these are two examples that I'm going to walk you through. This was an 80-year-old patient who came to us after being in a motor vehicle collision. So when she initially presented, her head CT was normal, and she had a lot of pulmonary contusion and liver and splenic laceration. So in the first 4 days after her MVC, she developed progressive ARDS and had really bad ARDS. And finally, we had no previous experience of putting trauma patients on Ecmo. This was our first patient. This was in 2014, where we put her on Ecmo. And then we did the measurements, and this was all, remember, retrospective study. And you can see this was something about 5 days into her Ecmo run, we noticed that she had pupillary exam change. So we then hiked her down for a head CT, and this is what we saw in her this one. When we went back and looked at the wavelet transform coherence, this was the 12 hours preceding the pupillary exam change. And this is the blood pressure on the left y-axis and the mean from the cerebral oximetry on the right y-axis. And you can see there's a nice correlation between the blood pressure and the cerebral oximetry, which means that she had disrupted autoregulation. The next one is another patient who was a 14-year-old female who came into us with septic shock, and later we found out that she had meningococcal sepsis. And right from the get-go, she had very poor, she had a lot of hypotension. We were not able to support her very well on Ecmo. And this is her wavelet, and you can see there's a lot of correlation. And after about 48 hours, we noticed that she did not move one side of her body. And this is the brain CT that we got. And finally, she had to be withdrawn from Ecmo. And so we now did this correlation, and we called it the autoregulation index. So then we studied this on about 47 patients or so, where, as I said, we calculated the autoregulation index, and then the neuroradiologist was blinded to the clinical exam, gave us a neuroimaging score, and then we asked the question, does autoregulation index correlate with neuroimaging? And we found a nice correlation. You do see a group of patients here who have high neuroimaging scoring, but who had very little autoregulation index. And of the 5 patients, 4 of them were oncology patients. And as we know, many of them already have brain atrophy, and this one when they have cancer treatments. And one of them was a neonate with group E strep meningitis, who we did not have the diagnosis when we put the patient on Ecmo. And then we divided these patients with ischemic injury or hemorrhagic injury. Then patients with no injury were considered normal, and then we bucketed them into blood pressure ranges for their we normalized their blood pressure, and then we looked at where does their blood pressure predominantly lie in their Ecmo run. And what we found was that the gray bars are patients with ischemic injury, and the dark bars are patients with hemorrhagic injury. So we found that ischemic injury patients had loss of autoregulation with high correlation with the WCOX index being high at the low end of blood pressure range, and patients with hemorrhagic injury having disrupted autoregulation at high blood pressure ranges. And this was a nice preliminary study because we now have also registry data to show that as well. So if I had to look at the cerebral hemodynamic curve on Ecmo, the hemorrhagic patients were at this side of the curve, and the ischia patients were at this side of the autoregulation curve. Now I'm going to switch gears. There are now not just us. There is a group in France which is doing a similar work where they are monitoring continuous autoregulation in children, and they have also shown some impact of arterial CO2 on the oxygen on cerebral perfusion. I'm going to switch gears and talk a little bit about diffuse correlation spectroscopy, which measures the movement of red blood cells and is a surrogate marker for cerebral blood flow. And this is a patient on Ecmo where you have the blood pressure on the x-axis and the cerebral blood flow on the y-axis, and there is no real correlation. The same patient, about 12 hours later, you can see a nice correlation with this. And in the interest of time, I'm going to skip this. These were patients who were enrolled in our study, and we found that early measurements were pretty helpful in diagnosing brain injury. So this is a pilot study that's currently being reviewed under in ASAIO, where we show again a nice correlation with neuroimaging, and that the diffuse correlation, if you looked at patients with low neuroimaging score versus high imaging score, they had a higher diffuse correlation index. We currently actually have an NIH funded study for this, and it's a single center study, and we are enrolling patients in Dallas Children's. And the specific aims of the study are to identify non-invasive optical autoregulatory biomarkers for neurological injury in the first 48 hours of Ecmo. We have so far enrolled, I think, 7 patients. So in conclusion, there is definitely disruption in cerebral autoregulation, and it seems like there is in-phase correlation is nicely correlating with neuroimaging, and in-phase coherence abnormalities may help predict neurological events. But what needs to happen in the future is really we need to be able to do this in critically ill patients while they are going on ECMO, because I do think it is the first 24-48 hours when we are significantly changing their acid-base status, their perfusion is when we are going to get maximum benefit by looking at this. And also, right now, all we are doing is retrospective. We need real-time measurements where I can come up to the bedside and ask them to give me readings for the last 3 hours where I can see the disruption and say, am I going to be able to do something about it? And then we are trying to correlate with neuroinflammation. And of course, long-term follow-up is where really the rubber hits the road, so to say. And I really could not have done this work without the help of so many people that are listed, and the grant support, including ELSO, which has given me very many small grants which has helped support the study. And certainly, last but not the least, my ECMO patients and the family. This is a reunion where we get all our children and celebrate their lives. And I'll be happy to take questions in the end. Thank you very much.
Next, we have the talk by Indra Jaikumar ma'am. She is a pioneer in the field of pediatric critical care. She has over 10 publications. Her area of interest include ECMO and formulating the protocols for pediatric trauma and ECMO. Indra ma'am.
Good afternoon, everybody. Thank you, Swakal and DMCH, totally soaking in the hospitality and the food. So I'm just going to take you through to the indications for pediatric and neonatal ECMO. And are children any different from adults, or are they just half adults? No disclosures. So when we debate, when we get a patient who's possible an ECMO candidate, we oscillate in our minds between ventilation and cannulation, knowing very well it is potentially life-saving, but it's complex, resource-intensive, very expensive. And though it was popularized in neonates initially, our adults in India have taken over the ECMO runs. So you can see this is January 2020, and we have neonatals, ECMOs, maximum runs with good outcomes for pediatric pulmonary indication 73%. Pediatric is about 60%, and the adults were still lagging behind. But then, like the H1 pandemic, we had COVID, and adults have world over, including India, have more runs. Neonatal is still the same, outcomes also pretty much the same, but what about India? In India, we have more adult ECMOs. Adults are doing pediatric ECMOs, and the neonatal are the least, though ECMO started in neonates initially, and even this data is most in the post-op cardiac situation. So who should go on to ECMO and who should not? So these are the questions that we always ask. What is the path ahead with ECMO? Is ECMO more likely to help or hurt? And just remember, this is something that we have learned through past experience. We only regret the chances we didn't take. We know that timing is everything. Don't blame the technology, blame the timing. It's pointless initiating ECMO if you have severe multi-organ dysfunction. You're going to have poor outcomes. So what exactly is the timing, ideal timing? So there is decreased survival odds when the pre-ECMO ventilation exceeded 14 days. So there are enough evidence. But with lung protective ventilation, one has to individualize, and there's very good outcome with viral pneumonias. With regards to less than 7 days or 10 to 14 days, didn't really matter. So the earlier the better, at least before 14 days in pediatrics. So the Berlin criteria is there in adults. We have the PARDS criteria in peds. And you can see Ecmo is offered there as part of the algorithm right on top. And it should be considered in children. This is the latest guideline from the PALIC. And there is no single criteria for selection of children who will benefit from Ecmo in PARDS. So what are the criteria, or what are things that you could, so it could be not, it's not just one, it could be multiple, and also the rate of deterioration and how quickly Ecmo can be initiated. So you have OI. In fact, many centers across the world are initiating Ecmo at much lower OIs to have better outcomes. AADO2, a PF ratio with high ventilator settings, lack of response to conventional therapy. Hypercarbic respiratory failure, and this is another in children where ventilation index. So a lot of children, even for asthma, have had ECMO for 2 to 3 days. Viral bronchiolitis, we have currently one patient in our unit for viral bronchiolitis, metapneumovirus. Air leak is yet another indication in pediatrics, and those with bronchopleurophystular. Remember, when you have air leak, you can even do away without the ventilator till the air leak resolves. And as was also mentioned by the previous speakers, before introducing a chest tube, beware, you could actually convert a pneumothorax to hemothorax. And so you have to be very, very mindful of your anticoagulation and only do insert a tube if there is hemodynamic compromise. Intraoperative tracheal surgeries in children have been done on ECMO, post-op recovery or lung recovery as well, mediastinal masses biopsy, and any procedures, lung procedures. So you can see there's an explosion of indications for respiratory ECMO in pediatrics. Hydrocarbons, so in India, kerosene aspiration, paint aspiration, paint thinners. So these are some things that we should be giving because these kids are so salvageable. Pertussis, foreign body retrieval also when it becomes very tricky. COVID was another indication, burns with ARDS. Now, ASA algorithm, difficult airway in pediatrics, you can see ECMO right there. And you should have the ECMO team on standby when you're having a difficult airway. Trauma, post-traumatic ARDS, is no longer a contraindication for ECMO. And we all know that we can perform ECMO even without anticoagulation. So you can see our indications are expanding. What about immune-compromised patients? Even they should not be denied ECMO if their underlying condition is treatable and they have a good potential for good survival and good quality of life. So neonatal ARDS, there is also a similar classification with the indications pretty much similar to that of pediatrics. OSI, this is a term, you can't be pricking children. Arterial line placements can be pretty, challenging. So OSI, this is, you can continuously monitor and see whether neonate needs ECMO. So where the PaO2 is replaced with saturations, and these are the values. So meconium aspiration, Dr. Sunil has already mentioned PPH and air leak. For diaphragmatic hernia, we initiate ECMO at lower OIs. So the contraindications have shrunk, and ECMO can be offered to so many pediatric and across age groups, pediatric as well as neonates. So what is the type of cannulation you would do in ECMO for pediatrics? If it's ARDS, we know venous is ideal, even in conditions of pneumonia with shock, because we know it's the RV that's failing, and once you correct the acidosis and hypocarbia and offload the RV, you will actually have blood pressures that shoot up, and that can cause intracerebral bleed because from hypo you're going to hypertension soon after initiating ECMO. Now, small vessel size, femoral vessels limit the cannula size in children. In India, we do not have the dual lumen cannula, that's ideal, and it's expensive as well. So at the moment, we do neck VA cannulation. That's a lot better for infants and neonates rather than your sternotomy for meconium aspiration and other ARDS situations. So we would do femoral IJV cannulation for children about 20 kilo and above 5 years because the femoral veins have to be very good for good drainage. Now there is, with regards to carotid, whether you ligate or you repair the vessels, there's minimal difference in outcomes. VV, bicable dual lumen cannula, that is the best, even in newborns, but it's not available in India. And this is by Lakshmi, a very, very important study. So changes in CO2, you don't want to drop in CO2 and a rise in blood pressure soon after initiating your VD ECMO. So because that can cause intracerebral neurological complications. How do you prognosticate? How do you counsel families? You can check your ELSO guidelines and resources, and this is something for pediatrics as well as neonate. You can predict the survival or mortality while counseling your families, but it is not for patient selection of ECMO. It is just to give a rough idea. For challenging situations, chubby children, open cut down and Seldinger is better than just blind percutaneous, so you don't injure the vessels. And if we have had challenges, if you make the mistake in not putting the correct femoral drainage cannulae, if it's not long enough into your hepatic IVC, you'll struggle with drainage in pediatrics. And this we had to do a triple, we had to put 2 drainage in the femoral. So very, very important when you start the ECMO. What's difference with regards to ventilating these children? The same, lung rest, low driving pressures. Many of viral pneumonias are not recruitable, so even 8 to 10 PEEP is okay. But if you've got a lot of obesity, a lot of pleural fluid edema, then you could go up a little more and PEEP. The tidal volumes can be single digit for days. Fluid overload, already alluded to, is associated with worse outcomes even in pediatrics. Proning, a lot of studies on ECMO, pediatric ECMO, it's doable, it's easy to flip the children prone, and there are not very many complications, but this has to be done with the entire team, with your perfusionists and cardiac surgeons. Tracheostomy, early versus late, anything more than 21 days is late tracheostomy, and no tracheostomy actually has more mortality, so it helps your sedation, clearance of secretions, and there's enough data to show that you can do tracheostomy on ECMO in pediatrics. Flexible bronchoscopy, better to do early, clear your secretions, open up, and it has shown to have give more ventilator-free days and shorter ECMO runs. Awake ECMO. So, well, we have not done it yet. Neonates a lot easier, but in children, you don't want them yanking off the tubes. So that has to be carefully weighed. Kids won't understand. So that has to be individualized. Please get your imaging. Cannulae have migrated, and then you'll be troubleshooting without knowing where your cannulae are. Ultrasound lungs and cranium in small infants. Bedside ultrasound is so very useful. Your pre-ECMO, after cannulation, during ECMO, daily troubleshooting, weaning. It actually helps you stratify whether you have to go on VD ECMO or VA. If your LV is also failing, then you would choose VA ECMO. Nursing team, it is so important. Educate them, and we all know it's 2:1 nursing. So I think we have to also have many more workshops like this for the nurses. Survival in children. So our first ECMO patient was for ARDS, was a scrub typhus pneumonia. She had 3-digit PCO2, 6.9 pH, and she got very good marks. She's now studying to be a perfusionist. So lung has the potential to heal even after a long time. VA ECMO has more complications than VV. So for pulmonary pediatric ARDS patients, it is VV, even if they are in shock. Of course, the underlying disease will determine the outcome if you're immune deficiency or transplant or pulmonary hyperplasia and diaphragmatic hernia. But remember, it's not the technology, it is how you use it, your anticoagulation, ventilation, fluid management. Be obsessive about your fluid balance every day. Dialysis, all these can make a lot of difference. So my message is a timely ECMO for pediatric ARDS refractory hypoxemia can be life-saving. Don't delay. Outcomes are poor if instituted after irreversible ventilator-induced lung injury, your MODS. Remember, FiO2 is also very toxic. It's not just your ventilatory pressures. And VD ECMO is preferred for ARDS hypoxemia, even in patients with shock. Thank you.
I think we are open for the discussion now. I think the message is very clear: start early. Don't delay until it goes into irreversible phase. And we are underestimating the pediatric and the neonatal population. That's what I can understand. It started from the neonatal and it's now the adults have taken over.
I have a question for the first speaker, ma'am. Do we have the rough surrogates for the resistive index in like neonates when we are doing the bedside, say ultrasound cranium and they are on ECMO? Do we have any data on RX?
I don't think so. So the resistive indices has actually been done by transcranial Doppler as well. Tracy O'Brien has published a very nice multi-center study where they had, I think, probably close to 140 children, and they looked at systolic resistive indices, diastolic resistive indices, and they did not find anything helpful. But the pulsatility index was something that they found that I don't want to quote the paper wrong, but in my remembrance, I think the pulsatility index was lower in patients with neurological injury compared to other patients. And in ultrasound, we do a lot of ECMO, high volume ECMO center. So we do a lot of ultrasounds. And if I were to say from my experience when I read the ultrasound report, there is always a change in resistive indices when you cannulate the carotid artery. But what does that mean in terms of long term? I don't think that is anything. In fact, um, Anne Marie from Toronto Sick Children they are doing a very nice study where they are looking at carotid artery cannulation and what is the long term outcome. It's a very nice study that they have launched. And we are hoping that with our neuroradiology colleagues, we are going to be able to do arterial spin labeling for patients. But the problem is we don't have, after reconstruction versus no reconstruction, we don't have enough population to compare. So it's a good start.
Thank you. Thank you.
So much to what we think, yes, BA definitely causes more neurological injury, but it does not mean that VV patients are benign, that they don't have autoregulation disturbances. So in our cohort of 47 patients that I showed the data on, we had both VA and VV patients. And we did find that you had autoregulation disturbances in VV patients as well. But certainly, disruptions are more in VA patients, neurological injuries are more in VA patients. There was a previously published study where we took all our MRIs in the last 10 years and we classified the neurological injury, and we found that the ischemic injury was more in VA patients compared to hemorrhagic injury. And the neuroimaging scoring was higher, which means worse for patients on VA. But
So when you are having this disturbances in VV ECMO, do you think that they are attributable to the ECMO itself, or because the disease which the child is suffering from internal dysfunction?
I think it is a combination, isn't it? You take some of the sickest patients, for sure, it is their underlying disease process. In fact, we are working on a prediction modeling of who is at risk for neurological injury. So we start looking at pre-ECLS and on-ECLS factors. Of course, their degree of sickness is certainly a ticking time bomb. You take a septic shock patient who is hypotensive, who is acidotic, and you cannulate their carotid artery and put them on ECMO, for sure. I think they are at much higher risk than a 14-year-old who is hemodynamically stable. All they are is severe ARDS, and now you're putting them on a planned 3-hour time where you're thinking about what is the right cannula and you're putting them on VV. That patient is certainly at much less risk than the first patient. But does this patient have completely is excluded from having neurological complication? I don't think so. So I think that's one of them. Matt said it very nicely in the talk this morning. I think neurological injury is where we need to get to, like where cardiac ECMO is these days. How we have to learn what, and there is a lot to learn, lot that we don't know.
Do you look at this type of regulatory regulations in those small kids who are in CRRT or SLED or hemodialysis? Yeah, did you look at those investments?
Unfortunately, we don't have the numbers to power everything. And I'm hoping that we are hoping to launch a multi-center study looking at all of this. And maybe 5 years from now, in the Saw Council conference, I may have some answers.
So is the difference between the VA and VB, is it explained by thromboembolic events or is it explained by perceptibility?
I don't know. Correct.
So,
Can the drainage affect?
Yeah.
I think Roberto Lorusso, they looked at actually the ELSOR registry and compared femoral cannulation, Jew neck cannulation, and also there is another study where they have looked at large-sized double lumen VV cannula and looked at increased neurological complications in those patients. I think that has been published. And our explanation is probably venous congestion and inability to have adequate venous drainage.
So
Um,
if you use second
Cephalad cannula. I think. Oh, there he is. Correct. Ask Matt.
Put him on everybody.
Put him in, and everybody is what he will say, but I will say don't. That's not my experience, but his experience is much more. They have done a lot of very successful cephalad cannulas, and in fact, I think was it your center that published the data on neonatal Ecmo showing that cephalad cannula did not increase neurological complication. I will say that our experience, actually, we had a neonatologist who came from their center and wanted everybody to have a cephalad cannula. Our experience was that we didn't have enough numbers to look at neurological complication, but our experience was that they had significant increased hemolysis. And so we actually went away from doing cephalad cannulas. Yeah, so I don't, but certainly I think venous drainage is an important factor, but how much and this one, I don't know. And if is cephalad the solution, I don't know. Short answer, I don't know, is the answer for many other questions.
No, I just wanted to make a comment about, whether it is the tool, that is the Ecmo tool, that's causing the complication, or is it the patient? I think that's a very important thing. But I do believe that if you have a very sick patient, whether it is, whether you do VV or VA Ecmo, it's the critical ill patient that leads to neurological complications. And then if you have, of course, if you have a cardiac arrest, that gives a different dimension altogether. So I think I would say that there's a lot of education that needs to be done in pediatric ICUs to say, refer early if there's a problem, or refer in a multidisciplinary team group, so you're sort of monitoring and you identify the patient early. Of course, you will have some situations where patients will present in a peri-arrest situation, and that's a different one. But setting cerebral autoregulation, I think, is the key, and I wish we could, monitor it much more effectively at the bedside.
But I think one thing now, based on the neonatal publication in ASAIO, our data in pediatric ECMO, and Eddie Fan's paper in adult ECMO, all the three have shown rapid changes in CO2 does increase your risk of neurological complication. So if anything we want to do well to avoid neurological complication, one thing that is probably under our control is to decrease your CO2 gradually. And in fact, the patient that I showed in 2014 after the TBI who got the intracranial bleed, after that we have a protocol where we match the PCO2 of the patient in the ECMO circuit by bleeding in more CO2, and then we take time to decrease the CO2, and how long we take it, at least 2/3 the time that how long we have remained in the high CO2. So I think if one thing we can do, we should probably reduce the CO2 slope. I think now based on the ELSO registry data. It's been shown in neonatal, pediatric, and adult population.
Thank you, ma'am. That was a lovely discussion.
Thank you to our speakers and chairpersons for such a good session.